Welcome to our case presentation for our chapter on the endovascular treatment of extracranial carotid stenosis. Herein we present a case presentation of carotid angioplasty and stenting. Our case presentation is a 59-year-old gentleman with previously treated left carotid artery stenosis with recurrent symptomatic stenosis. As you can see, this gentleman has previously undergone an angioplasty and stent and has recurrent stenosis, one of the stronger indications for repeat carotid artery angioplasty and stenting. As discussed in our chapter, pre-procedurally the patient has been reloaded on dual antiplatelet therapy. Prior to angiography, discussion is had with the anesthesia teams for the potential of bradycardia at the time of angioplasty, and preparations are made for heparinizing the patient during the course of the procedure to minimize thromboembolic complications. Routinely, these procedures are done with standard right femoral access, which in our practice involves a femoral artery puncture with a 19-gauge single-wall needle and a Benson wire. A 6 French shuttle is entrained over the wire into the descending aortic arch, where it is flushed and attached to a pressurized heparinized saline fusion. There, using an intermediate catheter, the vessel of interest, in this case the left common carotid artery, is selected. From here, the shuttle is brought to the proximal left common carotid artery and flushed. Here, control angiography of both the cervical common carotid artery and the cranial projection are performed. At this point, measurements are performed both for the distal protection device, in this case an angioguard, as well as for the sizing of the balloon, as well as the stent. You can see the X1 marker measured distally is the approximate location of the distal protection device's deployment, and then the proximal X2 sizing for the approximate stent size. Further measurements are then made to dictate the length of the stent and the sizing of the angioplasty balloon. At this point, preparations are made on the back table to prepare the distal protection device, the stent, as well as the angioplasty balloon. As these procedures are performed under sedation, the potential for patient movement is always a concern. Use of landmarks, notably the cervical spine and relative position of the stenosis, or in this case the relative position of the stenosis within the prior stent, are useful guides for approximate landing zones for the angioplasty balloon as well as the carotid stent. We then move forward with crossing the area of stenosis with the distal protection device, deploying the device in a straight segment of the vessel. After the device is deployed, the angioplasty balloon is brought over the wire into the area of stenosis. Anesthesia is warned of potential for bradycardia, and the balloon is inflated. The balloon here is readjusted to maximally expand the area of stenosis. balloon is then rapidly deflated, removed, and the stent subsequently placed over the wire and deployed at the area of stenosis. Prior to removal of the distal protection device, angiography is performed to ensure that no further angioplasty is necessary and that the entire area of stenosis is covered with the stent. The distal protection device is then resheathed and recaptured and removed from the system. Control, cervical, and cranial angiography is then performed. Thus concludes our case presentation.